Dr. Joe Goldstridge is joining us from Des Moines, Iowa, from Cali Springs Wellness. He also consults with Aunt Zelda's Collective out in California. And I'm just going to let him speak for himself.
Okay, thank you.
Thank you so much for joining us today.
So I'm a retired cardiologist. I'm board certified in cardiology and internal medicine, and I was a cholesterol specialist in my other life as well. And when I retired, I didn't have enough to do, and I got depressed, and I discovered cannabis, which I'd been interested in for most of my life. But I discovered that I could apply some of my medical knowledge and have a new career. And so I've been doing that for a few years now. I joined the Society of Cannabis Clinicians in California, and early on I heard Maura Gordon talk about what she was doing, and I was very impressed. I was working in a clinic in Oakland giving recommendations, and after about a year of that, I realized that even though I had talked to thousands of patients and given them their credential to get their cannabis, I really didn't know how to treat people with disease who wanted to use cannabis. So that was bothersome, and I was looking for a way to become a real doctor and prescribe cannabis and help people use it. And when I came to Denver in September of 2014, I heard Maura speak again and talk about her work with cancer patients. And after that presentation, I started making contact with Maura and asking her to take me on as her apprentice. And she eventually agreed to do that. And for the past year and a half, I've been working with Maura. And since the beginning of the year, I've been seeing the patients that would normally be seen by Maura. So I've seen about 200 cancer patients so far, and that's my personal experience. And I'm going to talk about the cancer from my perspective. I'm going to talk about seizures, pain management, and immune disorders based on a review of the literature that I did recently. And I'm going to talk about some software that's under development, that's in the beta stage, that I've been using, that has, I believe, great potential for the future. So there are a lot of challenges to doing what I do and what many of you do, and it's not so easy. We can't always track the progress of the patients. We lose contact. We don't always have availability of medicine. I consult with patients from all over the world, and people in Scotland and France and Puerto Rico and Canada can't always get the best medicine that's going to be most helpful for them. So it's a challenge to do that. It's a challenge to find the therapeutic protocol with every single patient. There's some conditions which I've seen enough of now that I pretty much know without doing any additional research. But for many patients, for most patients, I have to research at least the drugs that they're taking, because there are significant drug interactions with cannabis, particularly with CBD. The CBD is an inhibitor of the cytochrome P450 system. THC is as well, but not to the degree as CBD. And many of the chemotherapies are metabolized in the cytochrome P450 system. And when that's the case, You have to be careful because if you block the metabolism, you will get increased toxicity from the chemotherapy. And most of the patients are on chemo. And then another challenge, and this one was just published this past week by the medical, the Federation of State Medical Boards, and I think we can no, I don't think I can get on this. Anyway, this is the link to if you go to JAMA and put in Federation of State Medical Boards, you will see this document that just was published last week. They have incorporated some of the bad things from Colorado. For example, they say in their report, in their recommendations for all state medical boards, that if a physician is using cannabis, they are by definition impaired. So there are challenges there as well. All right, so now I'm gonna show you some of the literature review that I did recently on seizures, pain management, and autoimmune disease. So this was a paper that was published last year. That's a pretty good review of the literature for the treatment of seizure disorders. Now, if you just saw the Sanjay Gupta video or the presentation, you would think that using CBD for seizure disorder was just a slam dunk. You just throw CBD at it and the seizures stop. But that's really not the case. As you can see here, only 9 of 23 patients experienced greater than 50% reduction in their seizures. Here, median reduction in seizure frequency was 43% for all patients with Epidiolex. So it's not a slam dunk, and you can see here as well, 32% of patients had more than 50% reduction in their seizures. Here, 57% of responders reported an improvement. It's not a slam dunk by any means. Now, this is an interesting slide, and you can see everybody talks about Dravet syndrome. And with Charlotte Figge with Dravet syndrome and how CBD is so effective, but you can see if you look at the literature, it's only about 23% effective for Dravet's. It's much more effective for the Lennox-Gastaut, and it doesn't work at all for this syndrome. Another interesting finding was that those patients who had moved to Colorado were more than 3 times likely to report a greater than 50% reduction in seizures than those who had a pre-existing residency. I thought I'd spring that on Colorado.
What do you draw from that?
Pardon me?
What conclusion do you draw from that observation?
I don't know, except there's a lot of mental overlay, a lot of placebo effect, and the placebo effect does play a role. And if you pick up your family and move, you really are determined that that's going to work, and so that plays a role. So what we know is that the endocannabinoids are in newly diagnosed patients, there is a deficiency of endocannabinoids. Now, when I was working in Oakland in the clinic giving recommendations, I saw a lot of patients who reported that cannabis was effective treatment for their seizures. Now, virtually all of those people used THC. Most of them had never heard of CBD. This was 2014. This was before the Sanjay Gupta presentation. And so what I learned from that experience is that THC is an excellent anti-epileptic. And that sometimes it needs to be combined with CBD. You can't just use CBD. And I think anybody that treats a lot of seizure disorders knows that the CBD will not, sometimes it works for a while, and then sometimes it stops working. So we still don't know how it works. It's not complete, the mechanism is not completely worked out. CBDV also has anticonvulsant activity, and there are people now talking about when CBD stops working, adding THCA to the mix and getting effective anti-seizure medicine. However, I did a Medline search for THCA and anticonvulsant and/or seizures, and there was nothing in the literature. So there's no science behind the THCA, but it is generally thought to be helpful as an addition to seizure medicine. So there are a bunch of trials ongoing now. I don't know if any of them incorporate THCA or not. So moving on to pain management, there were 2 big review articles in JAMA last year. One of them that was only based on 28 randomized clinical trials found high level of evidence that cannabis is effective for pain management. In the second study, they had more trials, so they had trials that probably weren't as good, and the level of evidence was not as high. Low quality evidence suggesting cannabinoids associated with improvement in nausea and vomiting. Cannabinoids were associated with an increased risk of short-term adverse effects, which we all know. So how do I approach a patient who wants to use cannabis for pain? We know the way that I start is with THC dominant strain. If the pain is obviously of neuropathic origin, I will add CBD sooner. And the dosage can be pretty high. I start usually with just 5 milligrams of THC, and if I add CBD, at least 25 milligrams, and or 10, 25. Actually, I use a lot of CBD when I add it to the THC, because it doesn't have psychoactivity and it complements the THC very well. Now, sometimes there is an interaction between CBD and THC. CBD is a partial antagonist to the CD1 receptor. So giving CBD and THC together may lessen the effectiveness of the THC. So sometimes if you separate out the THC from the CBD, you will get a more effective pain management. And this is, we'll talk more about separating them out for cancer management, because that is the way that I believe is the most effective for managing cancer. So who knows why I have Tylenol in here?
Because it affects the endocannabinoid system?
Pardon me?
Because it affects the endocannabinoid system?
It does. It does. So one of the metabolites of Tylenol
inhibits the uptake of anandamide, increasing concentrations of anandamide. And so Tylenol is active on the endocannabinoid system. That's why it's doctor's choice with pain medicine. So my concept of cannabis and the immune system is that THC binds to the CB2 receptor, which is in the immune cells. The levels of CB2 expression vary from different immune cell populations, with the beta lymphocytes having the highest level of CB2, followed by macrophages, monocytes, natural killer cells, and polymorphonuclear cells in that order. This was research done in 1995. Early studies concluded the distribution of CB2 was confined to peripheral non-neuronal sites. However, it is now recognized that CB2 is expressed by a variety of subsets of immunocompetent cells found in the nervous system. Moreover, CB2 has been reported to also be present on neurons. So not only the CB1 receptors, but the CB2 receptors are more ubiquitous in the body than initially thought. So again, when I think of immune disorders, I think of CB2 and THC. We'll talk a little bit about CBD in just a minute. While a large body of data from in vitro studies and animal models indicate that the immunomodulatory activity of THC and CB2 agonists can lead to decreased resistance to infections, this hasn't been demonstrated in humans as yet. But theoretically, you would think if you made these immune cells less active, that you might have more infections. But that has not been the case. And here's a study about THC and killing the HIV virus, at least in monkeys, immune system properties. And beta-carotene is a full agonist of the CB2 receptor. So this is a terpene that can attach to the CB2 receptor, just like THC. So the terpenes are important. So these are the conditions that have been shown to be benefited by THC. I've treated a few patients with MS, but I saw this paper just last year, and since I've seen 2 patients with MS, and I totally changed my approach. Because CBD has the potential alone to stop the death of neurons in experimental multiple sclerosis. So if it were able to do that for humans, you might be able to block the disease with high-dose CBD early on in the course of the disease. So I've changed my ratio of CBD to THC for MS, now with a predominance of CBD for new diagnosis patients. The THC may be better for modulating the symptoms, but the CBD may be more important in arresting the disease. Now, a lot of people talk about CBD being beneficial for autoimmune disease, but I couldn't find that in the literature, and I don't have enough experience in treating autoimmune disease to know from my patients. But I did a search going back to 1998, and I found some evidence that cannabidiol limits T-cell mediated chronic autoimmune myocarditis. This is an animal model, and the MS that I mentioned on the previous slide, and then this is the MS animal, this is the animal model in mice that is the closest to multiple sclerosis in humans. And there is some evidence that CBD is beneficial, and that's supported by the previous article. And an autoimmune hepatitis. Diabetes, you know, I trained as a diabetologist early on in my career. I never thought of diabetes as an autoimmune disease, but it's now considered to be an autoimmune disease. And so you could wonder if you had a family with type 1 diabetes and they had children, would perhaps treating these kids with CBD when they were young, would that perhaps prevent them from getting diabetes? That's just a theoretical question that comes to mind. Okay, so now I needed a little filler because I didn't have enough to talk about for the whole time about cancer. But cancer is what I'm about. That's what I do. Those are the patients that I see every day, and this is really what I want to talk about. So, first of all, one size does not fit all. The Rick Simpson a gram a day, that doesn't work. That's not real. There is a provider of cannabis oil in California who gives everybody a 4-to-1 ratio of THC to CBD. Everybody gets the same thing. The oil, it's one oil with both the THC and the CBD. And this past month, I saw 3 patients whose cancers grew on this regimen, and one died about 2 weeks after deciding not to do that anymore and to try something else, but it was too late. So the fixed ratios, and in my experience, it's better to separate out the THC from the CBD. As I mentioned earlier, the CBD is a partial antagonist to the CB1 receptor, and it may diminish the ability of THC to induce apoptosis in the cancer cell via activation of the CB1 receptor. But I'm getting ahead of myself. So there's a gene called ID1. It's a DNA. It's a gene that governs DNA replication. And there's been a lot of research, primarily by Sean McAllister at Pacific Medical Center. And he studied mainly breast cancer and glioblastoma. And he's shown that CBD is effective for these 2 cancers. And what CBD does is downregulate the ID1 gene. The ID1 gene is responsible in a large measure for metastasis of the tumor and for growth of the tumor. And when CBD acts on the tumor cell, it does not induce apoptosis, which is programmed cell death. It induces autophagy, which is another form of cell death. And so what we have done is extrapolate from the work that McAllister has done in glioblastoma and breast cancer and look for any tumor that's associated with the ID1 gene. So when I see a new patient who has a tumor that I'm not familiar with, and I'll show you an example in just a minute. The first thing that I do is do a search both in Medline and in Google, and I put the name of the tumor, maybe a neuroblastoma, and ID1. And I want to see if ID1 is associated with that tumor. If ID1 is associated with that tumor, I'm going to use more CBD than THC initially, most of the time. So I do the search in both to look for the ID1. We'll talk more about that in a minute. Now, the cytochrome P450 system is the major drug metabolizing system. It's in the liver. And most of the medications that patients are taking, most of the chemotherapies are metabolized in the cytochrome P450 system. CBD inhibits the cytochrome P450 system, and THC does as well, but CBD is much more potent in that regard. So if you had somebody who was taking a chemotherapy that's metabolizing the P450 system and you put them on high CBD, the blood levels of that chemotherapy are going to go high, and the chance of toxicity from the chemotherapy is greatly increased. Also, there are a number of drugs that are prodrugs. For example, tamoxifen. Tamoxifen by itself does not have any estrogen blocking activity. A lot of women with breast cancer are given tamoxifen. So if you give tamoxifen with CBD, you may prevent the tamoxifen from actually working. It may not be able to be converted to the active metabolite which blocks the estrogen. So I had a patient not long ago who was on tamoxifen, wanted to use cannabis. I wrote a letter to the oncologist asking if she could substitute if she could substitute an aromatase inhibitor that was not metabolized by the cytochrome P450 system, and she was delighted to do that because she knew that the patient had a very aggressive form of breast cancer, and she was not confident that her chemotherapy alone was going to be effective in curing the patient, so she agreed to do that.
Question. Do you know which subsystem CBD is active at?
I'm hard of hearing.
Do you know which subsystem CBD is active at? 3A4, 2D6? Do you know off the top?
I can't understand.
I want to know which alleles in the P450 system you're addressing that would.
Right. There's 3A, CY 3A, and there's about 3 different enzymes in the P450 system that are affected by CBD. As far as dosage goes, the important thing for dosing is age. Children with cancer may require cannabinoid dosages above 500 milligrams a day. If you tried to give that to a 70-year-old, they wouldn't be able to tolerate it. As you get older, you are not able to tolerate as much cannabinoid as when you're young. So I have prescribed 4, 5, 6, 7, 800 milligrams a day for young children with aggressive cancers. And I usually start, if somebody's above 60, I usually start with
with a dosing protocol that's under 200 milligrams, sometimes even under 150. CBD, there's some research done with Sean McAllister again, and a researcher in his lab named Singer, who they have a tissue culture system where they add, and they can then add cannabinoids to the system. I'm sorry, I keep getting in your way.
No,
Keep-
we're filming
if you add, if you add vitamin E to a system where CBD is able to induce autophagy and kill the cancer cells, and you add vitamin E to the mix, it shuts down that reaction. So one of the important things when treating cancer patients is to make sure that they're not taking antioxidants with their CBD. So the way that I don't know if this is the right or the best or thing to do, but I'll tell you what my protocol is in just a minute. But I have the patients take any antioxidants like curcumin, which is a supplement that has antioxidant activity and has cancer-killing activity, and it's a good supplement. But I wouldn't want to give it to a patient who was also taking CBD and hoping that the CBD was going to kill their cancer cells and then inactivate that CBD effect. So I have the patients take their antioxidants at bedtime, and the last dose of CBD that they take is in the early afternoon. Talked about this. Whole plant, entourage effect, laboratory tested medicine, including terpenes, and alcohol extract medicine whenever possible, because the alcohol extracts preserve the most terpenes. CO2 makes a nice extract, but you don't carry as many terpenes along with the extract, with the cannabinoids as with alcohol. Any questions on this slide before I go on? Yes.
Where did you find that alcohol?
I have to speak up.
Where did you find that alcohol extraction preserves the most terpenes compared to the other extraction methods?
One of my associates who makes oil and lab tests it reported that to me. He had used CO2 previously, but then when he discovered that he could get more terpenes with the alcohol extract, he completely switched to alcohol extraction.
We found that butane does quite a bit better job than alcohol. Butane and actually heat press, the new rosin that we've been working on, smashes out.
So I've had, maybe you can educate me on this, but I've had reservations about butane because it is a toxic substance, and if you have any left, it's not good. So
It's very easy to get it out.
it is.
Yeah, we are non-detectable, especially any of our medical products that we're tinctures, very easy to get it out.
And the terpene level is better than alcohol.
Yes.
Butane.
Yes.
Thank you. So there are a lot of terpenes, but I did a search just recently for the terpenes that are most associated with anti-cancer activity. And these are the 4 reported in the literature.
Did you have a question?
Oh, I was just wondering if, yeah, I was wondering, could you repeat what you were saying about the vitamin E, about how it inhibits?
So in these cancer cell tissue culture
it's a standard laboratory technique. It's what Christina Sanchez uses in her research. And you can add CBD and show, and I'll show you a slide in just a minute that has killing cancer cells with CBD and THC both. But if you add vitamin E to the mix, it will block CBD's ability to kill the cancer cells. So I think it's really important. It's really important if people are going to use the cannabis not to inactivate its effects with other supplements that they're taking, even though they may be beneficial, not in conjunction with the CBD. Now, this is a slide, I know it's hard to read, but this is a list of cancers that are associated with ID1. So, bladder, breast, brain, colon and rectal, and those cancers induced by the virus, blocking the. Pardon me?
HPV.
Yes, the HPV. Esophagus, gastric, also the gallbladder cancer is associated with ID1, kidney, head and neck, and again, that head and neck is EBV. Some leukemias, Hodgkin's, non-Hodgkin's, and non-small cell lung cancer, prostate, thyroid, ovarian, nasopharyngeal, again, that might be EBV, liver, are all associated with ID1. So, but you have to, if you have a cancer that's not on that list, you have to do the search to see if there's an association with ID1 or CBD. So I had a patient with a young child with neuroblastoma, and I did the search. That's not on, the neuroblastoma is not on the ID1 list, so I was thinking, well, it's going to be more THC, not so much CBD. But I did my usual search to look for relationship between neuroblastoma and CBD, and I came across this article which was just published in March, and I was particularly impressed to see that Dr. Meshulam was one of the authors. He's one of my favorite, he's a hero, and so in this study, they actually showed that CBD alone was better than THC in killing the cancer cells. So if you do those searches, every time you see a new patient with a new tumor that I'm not familiar with, then I can continue to learn and refine my therapeutic protocols in treating these cancer patients. So this is the kind of study that was also the kind of setup that was used to show that the antioxidant vitamin E was able to inhibit the killing of the cancer cells. So this is the neuroblastoma. This is with 50 micrograms per milliliter of CBD, and this is with a higher dose. And you can see with the higher dose, there are more cancer cells that are not present, that have been killed. I saw another article just in the past week or so that compared CBD isolate to CBD whole plant. And it was a very interesting study because CBD isolate
killed cancer cells up to a point. It was like a bell-shaped curve. And then as you increase the dose of the CBD isolate, the cancer-killing ability diminished. But if you use whole plant CBD along with the entourage, there was no decrease. Just like in this study, the higher dose resulted in more cancer cell death. So whole plant is better than the isolate. Yeah.
Regards to whole plant, are they using a whole plant that has very little THC?
So let me tell you how I dose for cancer, and you'll understand. I use high THC strains, and I use high CBD strains. The dispensaries in California, some, not widely, but some, make oil from the ACDC strain, which is anywhere from 1 to 12 THC to CBD to 1 to 30, depending upon various factors in the growth of the strain. There's a strain now called Valentine X, which is just an ACDC on steroids, because it's up to around the 1 to 30. But the average ACDCs will run more in the range of 1 part THC to 20 parts CBD. So the way that I dose is I have patients take a high THC strain first thing in the morning, just to activate the endocannabinoid system. Whenever possible, a stimulating strain. And the morning dose is usually 10 to 25% of the total THC dose. Typical THC doses, total THC, may be anywhere from 75 to 200, 250 milligrams a day. So 10 to 25% first thing in the morning, the remainder of the THC at bedtime. And whenever possible, a sleepy strain at bedtime. Most of the time, people will use the same strain in the morning and at night. About 3 to 4 hours after the morning dose of THC, the first dose of CBD. The CBD is given in 2 equally divided dosages. The first dose of CBD 3 to 4 hours after the first dose of THC. The second dose of CBD about 3 hours after that. So that puts a fair amount of time between the second dose of CBD and the next dose of THC at bedtime. And that's when I recommend that any supplements that have antioxidant activity are taken. And so that includes vitamin D, curcumin, turkey tail mushroom, and one of my favorite supplements. Anybody guess the supplement that's an antioxidant that has the most research showing anti-cancer activity?
Turmeric.
What?
Turmeric.
Turmeric.
Vitamin C.
Melatonin. So I usually recommend that they build up, depending upon age. I don't use the melatonin for children. I think they probably are taking it on their own. But for adults, I recommend that they build up slowly and get the melatonin up to at least 20 milligrams a night, and sometimes even up to 40. If there's a hangover the next day, then you have to back down on the melatonin. And when I was 50, I got a hangover from 3 milligrams of melatonin. Now that I'm older, I can take 15 and not even know that I take it.
So quick question, when you're talking CBD, you talking 200 milligrams also, roughly, or?
Well, it varies. It varies. If it's an ID1, cancer, then I might start with 2 parts CBD and 1 part THC. And so the total amount of cannabinoid is dependent upon the age of the person. If they're 70, I might give them 50. I have a 67-year-old breast cancer patient who has been on 50 milligrams of THC and 250 milligrams of CBD now for 2 years. And
A lot.
she was sent home. She was sent home to get her affairs in order because she had failed 3 rounds of chemo, and they didn't have anything else to give her. So it's a lot, but it works, and she's doing just fine. So I mean, she still has cancer. She's not cured of cancer, but she's functional. She's enjoying her life, and she didn't die like they told her she was. So this is the software that I mentioned. It's called CDR Med, and I've been beta testing this now for about 6 months. And it has a number, it's an electronic medical record, and but one of the things that's built into it right now is the P450 interactions. So it will actually tell you when you have, the inducers are not so important. If somebody's taking a drug that's inducing the P450 system, I'm not concerned about that. I'm more concerned about the inhibition, because the inhibition will prevent prodrugs from acting and will prevent certain medicines from being metabolized and potentially reach toxic levels and increase the toxicity of the chemo. Yes?
Could you go back one page to that?
Wow.
Could you go back one slide to that address? Thanks.
Now, as I told you, I have been Laura Gordon's apprentice for about 1.5 years now. And before that time, she probably has seen 400 or 500 cancer patients. So currently, we have nurses that are following up. You know, if you do what I do, you don't schedule follow-up appointments. What I ask the patients to do is to send me the results of their new scans and their new lab tests that have the cancer markers, because I want to see whether the protocol is working or not. If it's not working, I will change it. I will change it. There are, if the cancer is growing, continuing to do the same thing and expecting a different result is insanity. So if I have a patient that I say has an ID1 cancer and I've given 2 or 3 times CBD over THC and the tumor is growing, I'll reverse that. I'll go with high THC and low CBD. So, because I don't, you know, I'm not going to keep doing the same thing. Why? That would be stupid. Yes.
Joe, how many different strains or products does Zelda Therapeutics, as an example, offer for sale to treat the various cancer and other maladies?
Well,
number of medicines varies, and the source of the medicine varies by supply. There's not, there may be, let me back up. What we found is that you can pretty much substitute THC from one strain or another and induce the apoptosis by activating the CB1 receptor. The exciting thing about treating cancer with cannabis is in the future. The terpenes are going to play a huge role. We don't know. We don't know. We have data on the terpenes since the lab testing that takes place includes terpene profiles. We have that data, but we haven't decoded that information yet. That may be one of the most important things that we'll learn going forward. And so this software is, right now, there are nurses doing follow-up on the 600 patients who have 600, 700 now, I don't know how many, and finding out what happened. Because when people come and they buy the medicine and they get the dose and the protocol, sometimes you don't get much follow-up. They may keep buying medicine, but I cannot be associated with a dispensary. That is prohibited from physicians, and that's part of the directive in the Federation of State Medical Boards. That they have that clause where a doctor can't work or have any kind of financial relationship with a dispensary. Although there was just a paper published this week showing that doctors who agreed to let a drug rep come in and buy them lunch prescribed more medicine from that drug company than doctors who didn't have lunch from that short skirt sales rep that came in and pitched the medicine. So it's strange, and also, we just had a meeting, I'm on the board of directors of the Society of Cannabis Clinicians, and we just had a quarterly meeting on Sunday, and we're going to draft a response to this JAMA article. If a physician is considered impaired, if he has a medical condition that responds to cannabis, what about the physicians who take an Ambien for sleep, or take a Xanax for anxiety? And these people that craft these rules have no understanding of the magnificence of cannabis and how much it can do and what a wonderful medicine it is. They have no idea. They just see it as something that gets people high. And they are so perverse in their thinking that they attribute the medicine and getting high, they equate those. But most people, 95% of my patients don't want to get high. They don't want the psychoactivity. And in fact, we have to figure out ways, because if they get too much psychoactivity, they're not going to take the medicine. They don't like it. So you have to figure out how to get them going. And sometimes I'll make the initial target dose much lower than I want, just so I can get them into it and let them build up some tolerance to the medicine. And then on the second round, after they're into it and they see that it's not an evil drug that's going to steal their mind, they'll be willing to increase the dose. In fact, I had a patient
on Sunday, I did the interview because I knew I was going to have a lot of time this week because I'm traveling. I had a 15-year-old girl who had Ewing sarcoma, and she went through surgeries and chemo, and she said, you know, she said, I really don't want anything mind-altering. She said, I had all these opioids when I was sick, and I didn't like that, and I don't want that. So I started her on an infused oil at very low dose and set the initial target of 25 milligrams of THC and 50 milligrams of CBD, even though I would like to use maybe 4 times that much. But we'll build on after getting started. Yes.
Okay. What do you do with benign tumors? Is there any difference in treating benign tumors than there is of cancer?
Such as?
Gliomas.
Glioma? Glioma is not a benign tumor.
I know it grows, but
It's not benign. It kills people.
we have treated some gliomas with CBD, Simpson, well, they've done beautifully.
Right. I think it's always good to have a little THC in the mix.
Yeah.
A little bit of THC. I don't ever, I won't say ever, but very, very, very rarely would I use CBD alone.
Joe, you've got about 10 more minutes left, so let's hold the questions and take those after.
Okay, I think I'm done. So I guess it's just some conclusions, and then I'll answer some more questions. So whole plant, activation of the endocannabinoid system, THC does that. We're going to learn more about the terpenes. Definitely one size does not fit all. Now, we have seen patients that did not respond. They were taking an oil that was like the 4-to-1 THC to CBD, and they were not responding, and the tumor was growing, and we split out the THC and the CBD as I described a little while ago, and then they responded. The tumor stopped growing. So that is the usual protocol now is the one that I told you about, THC first thing in the morning, and last thing at night, and the CBD during the day. All right, question. I take questions.
Yeah, I wanted to go back to your cancer protocol. With cancer, as with almost any disease, sleep is such a critical factor. And if we look at, where 75% of the THC is being given before bed, and it's 200 milligrams a day, so that's 150 milligrams possibly of THC before bed. There aren't going to be too many people sleeping very well with that.
Actually, that's, first of all, we build up slowly. You don't jump on that amount right away. And there's a strange phenomenon that I've discovered that if you take the THC and go to sleep before the psychoactivity kicks in, something different happens in the brain. I don't know what it is, but there's some other system, maybe the reticular activating system, maybe the limbic system, some other system comes into play, and the psychoactivity does not occur to the degree that you would get if you took that amount of THC in the middle of the day and didn't go to sleep. I don't understand it. So what guides me in whether it's too much THC or not, obviously if people can't sleep, that is a problem.
Well, then your 40 milligrams of melatonin will come in.
But then the other thing that I pay attention to is how do you feel the next morning? if they say, I can't wake up, I just feel lethargic, then I know that that's too much for them. And I'll back off. Because I do want people to sleep, because that's where healing takes place. But a lot of people who use cannabis for sleep find that if you took the same dose that you use at bedtime, if you took it in the middle of the day, you get wildly stoned. But if you take it and go to sleep and then wake up 2 hours, 3 hours later to go to the bathroom, you're not stoned. I don't understand it, and I can attest to that phenomena myself. Yes.
Would you see a reason to
Wait a minute,
not?
I have to come.
Sorry.
I got my hearing aids on max, I still can't hear.
So would there be a reason to not use CBN in that case? If
Oh, CBN is, CBN is the cannabinoid of choice, and it also activates the CB1 receptor.
Right.
But it's not so easy to find strains.
It doesn't produce naturally, but there is a way that you can
I know.
produce it.
And some of the best sleep medicine is high in CBN, of course. Yes.
Can you explain me again why separating THC and CBD works better than taking it together?
Yes, because CBD is a partial antagonist of the CB1 receptor. So you won't get as much THC binding to the CB1 receptor, and that's the mechanism by which you induce apoptosis in the cancer cell. So separating it out lets the THC have full access to the CB1 receptor.
We're going to take one more question now, and then we're going to hear from our other sponsor, and then we're going to return to more questions because I think we can go on.
I'll be here.
I would like to comment on the studies that you showed for seizure, pediatric seizures. I have been interned as you have with Margaret Getty. I've seen a number of pediatric